The AMDA, Acid Maltase Deficiency Association, was formed in 1995 by Randall and Marilyn House.
My wife and I became involved in this effort 14 months ago when our daughter Tiffany Laurel was diagnosed with Pompei's disease. Overnight, of course, our lives changed. It became very apparent to me that many in the medical community are totally unaware of this disease. Although her symptoms were numerous and persistent, nothing wrong, quote unquote, was ever found. When Tiffany was finally diagnosed at the Mayo Clinic last year, we were told that this disease is extremely rare, with only 50 to 100 reported cases. Based on our experience, I'm convinced that this is greatly underestimated. The purpose of this organization is to generate support for the scientific community so that development of enzyme and gene therapy for Pompei's disease can be realized. Over the past year, it's become evident to me that though there are many interested parties, there is a definite lack of communication between researchers in this field. You're all familiar with each other's work, but many of you never have met or even talked to one another. With this meeting, we are hoping to foster discussions which will hopefully lead to a cooperation amongst investigators. If this meeting does only that, we think it'll be a great success.
Through reading scientific papers on Pompe disease and reaching out to the authors of those papers, they learned that there was research being done at a variety of centers, including Erasmus University in Rotterdam, the Netherlands, Duke University, the NIH, NYU, among others.
From your research, it's very evident that enzyme replacement therapy is a viable option for the treatment of Pompei's disease. And we hope it's in the not too distant future. For my daughter's sake and the sake of the many patients that we have made contact with during the past year, we need to go forward with this project and bring the future within sight. I believe we're all aware of the progress that is being achieved towards development of a therapy for the treatment of Pompei's disease. It is truly amazing how much has been accomplished during the past 1.5 years. And Marilyn and I wish to thank you for all that you are doing to speed this effort.
In 1998, the AMDA co-hosted a conference with the NIH, and again, it was obvious that we were getting closer and closer to a treatment becoming a reality. 1999 was a pivotal year for the Pompe community. The first ever clinical trials for an enzyme replacement therapy started first in the Netherlands, using an enzyme derived from the milk of transgenic rabbits in January. Then in June, Duke University started a trial using an enzyme derived from a cow's cell line. Both of these trials were in infantile onset patients, but in June, the Dutch team also started a late onset arm of their trial.
The good news is there are 2 drugs in trials that we know work.
It was at this conference in 2001 that patients heard firsthand the results from the trials that started in 1999, and their results were clear. Enzyme replacement therapy for Pompe was no longer a dream or a hope.
We study correlation of genotype and phenotype so that by looking at the DNA we can give a diagnostic answer or a prognostic answer. And of course we have studied how to produce alpha-glucosidase, and also we are studying how to apply and evaluate enzyme replacement therapy.
But proving it worked was just the first step. At this conference, the FDA spoke about the process of taking a therapy from the lab to the open market. Over the next 5 years, trials would continue. There would be ups and downs, but we continued to move steadily toward commercial access to enzyme replacement therapy being a reality. 2006 was another pivotal year for the Pompe community, seeing EMEA and FDA approval of Myozyme, the first ever commercial treatment for Pompe disease.
I know 15 years doesn't sound rapid, but in this type of research, it is. Believe me. 13 or 14 years ago, there was no patient organization, and there was a very loose knit group of research scientists, and successfully got them together at many conferences like this, which expanded over the years and led to a joint effort of research, competition, involvement of industry, and led us where we are today.
It was clear that part of why we had made strides was the way the Pompe community worked together, but we also saw how much more we had to learn.
I will not go into much detail, but what is important here to remember is that 68% of the patients in our study with the IVS1 mutation had this haplotype, which means that the differences in haplotypes would not explain the differences between the patients that we found.
This case is a particularly interesting case because here's a brother and sister who have the exact same genotype, and yet the onset of their disease was very different. Her age of onset was 28 years old. You can see the glycogen buildup shown here. They have the same degree of residual activity, and yet his age of onset was 42 years of age. So we'd very much like to understand what these other genetic factors are which drive these differentials.
And we were beginning to learn about the benefits of newborn screening.
I think it's very clear that newborn screening will soon be a reality. There are currently funded pilot projects, one in Washington State at the current time.
Look at the older mice. If we treat them at 10 months of age, we can clear glycogen to a very large extent, but a lot of the nuclei are centrally located, suggesting that perhaps one reason why we were not able to completely rescue function is because perhaps the regenerative potential of these muscles is no longer possible.
The Pompe community is not one to sit quietly by. We are always striving for better treatments, better understanding, and better advocacy. Between 2006 and the next AMDA Patient and Scientific Conference in 2011, we continued to see advances, and we also learned about exciting new developments in the field of muscle regeneration and gene therapy. And newborn screening was once again discussed.
So you can see here that in the clinical diagnosed patient, although they may be 3 or 4 months apart from the newborn screening, but there's a decrease of the survival. Half of them, even with enzyme replacement therapy, still required ventilator support.
So this is a little child, I think I have shared this before, who was 14 months, was extremely sick, had very high titers and was very hypotonic and ventilator dependent. This is him at 66 months where his titers are less than 1 in 100. His heart has normalized and he's now immune tolerant and off all immune tolerant induction.
I hope that I can talk for everybody here. It was a really, from my point of view, a big success, and it was also very rewarding and stimulating to meet you all as patients. It also reminds me why we are doing the job.
In 2020, the world stopped. But eventually, the AMDA continued our important work. We added key personnel to expand our abilities and outreach. We pivoted to online webinars that were beneficial to both experts and patients alike, and we continued to provide important educational materials for patients and their families. And today, we are so grateful and excited to welcome you back to in-person conferences. Over the last 30 years, the AMDA has been at the center of efforts to educate, support, and advise the Pompe community. We have seen the dream become a reality. It's amazing how far we have come, but there is still work to be done. Our hopes and dreams have turned to better treatments, earlier diagnosis across the board, and access to treatment for all patients everywhere. Beyond the scientific impact, the AMDA conferences are an opportunity for patients to connect with each other, share their stories, and to connect with the scientific community.